Addiction is a learned behavior, and our external cues trigger those learned behaviors. And the classic phrase in 12-step like Alcoholics Anonymous is people, places, and things. So if you want to stop using, you really have to avoid the people, places, and things that you used with. Because what can happen is, even after a sustained period of abstinence, you can see a person that you used to use with or be in that old neighborhood where you used to use, and it can actually trigger cravings. We don't know exactly how this works, but it's a biological phenomenon where people experience the intense and very intrusive need to use again. So it's very important to change your environment to the extent that you can, so that you can avoid some of those triggers that have you craving, that can lead you to kind of dive into that behavior without even consciously being aware of it. With food addiction, it's the same thing. You know, if your thing is carbohydrates or Twinkies or whatever it is, like, don't have them in the house. Make sure that you're not hungry when you go shopping so that you don't buy them impulsively. All the types of things that I'm sure you teach people to kind of guard against creating an environment where they're vulnerable. If we don't anticipate those moments when we're vulnerable, if we don't anticipate those moments in advance, then when we're in the moment, we're likely to make a bad choice. So in order to self-bind and guard against that, you have to anticipate the moment coming and then say to yourself, instead of doing that behavior that I don't want to do, I'm going to do this other behavior.
Hey folks, it's Mike Meltzer here with HighIntensityHealth.com. Thanks for tuning back into another episode. I'm very excited today to be with Dr. Anna Lembke. She is an addiction medicine specialist and author of Drug Dealer MD, and we're going to talk about today natural ways to improve addictions and what really are addictions, and some of the information about the opioid and other chemical addiction, the epidemic that's going on. So Dr. Anna, thanks for coming on the program.
Happy to be here.
Let's kind of take a back step into the opioid epidemic and kind of look at where it started a little bit as kind of a solution for pain that kind of got spiraled out of control and has created a big mess. Yeah, so let's go back. But was this in the early 90s when things started to kind of form with this opioid recommendation for pain?
It really started in the 1980s, and it was part of a movement from within medicine to try to improve the treatment of people with pain. It was recognized then that we weren't doing a very good job helping people with pain, particularly at the end of life. That was also the time that the hospice movement was imported from Europe, and the hospice movement was all about making that transition from life into death more peaceful for people. A very compassionate, well-informed type of movement. But what happened was that that movement to help people in pain was co-opted by a bunch of different factors and forces, one of which was Big Pharma. And then it became instead a movement to increase opioid prescribing. And so doctors who initially set out to improve the treatment of pain began to collude with these other forces, and pretty soon the message is, we doctors have what was called opioid phobia. So we're overly fearful of prescribing opioids, things like Vicodin, morphine. We need to prescribe more of it in order to help our patients in pain. And of course, the pharmaceutical industry loved that message, and really co-opted that message and infiltrated various parts of medicine, including regulatory bodies like the Federation of State Medical Boards, the Joint Commission, even the FDA, in order to perpetuate this message that opioids were safe. And prior to 1980, doctors were understandably reluctant to prescribe opioids because we had experienced two major opioid epidemics in this country prior to 1980. One was in the early 1900s, when doctors were prescribing a lot of heroin. Heroin was even available over the counter at one point next to Bayer aspirin. And of course gave way to this terrible opioid epidemic in the early 1900s before it was made illegal. And then in the 1960s, during the Vietnam War, there was another heroin epidemic. So come to the 1980s, doctors only prescribed opioids for the last week or so of life, or if you had a major severe trauma like a serious motor vehicle accident, or when you were getting surgery, so perioperatively. Those were the only conditions. But starting in the 1980s, there started to be this message inside of medicine that it was safe to prescribe opioids for pain, for long-term pain in particular, so chronic pain conditions, and more people were presenting with chronic pain conditions, that opioids were effective for chronic pain. Now, we actually know today that that is not true, that opioids taken long-term do not work for pain. Opioids are fantastic short-term for pain, like over the course of, let's say, 3 to 7 days, but beyond that, they start not to be effective, and they can even increase pain by changing your overall set point for the experience of pain.
Wow.
And I can talk a little bit more about that.
Like substance P and things get down-regulated over time?
That's right. So that essentially you have a new pain threshold. So that the opioids are started to help with pain, but over time change the pain threshold such that you're more likely to experience pain. And that's what we see that clinically all the time. So basically 3 myths were propagated by this movement, which was aided and abetted by the pharmaceutical industry. One was that opioids work long-term for pain. We now know that's not true. But doctors were told that it does work and that it was an evidence-based approach. And once doctors hear that it's evidence-based, they're like, oh, I better do that. Right. The other myth was that as long as you as a physician were prescribing to a patient for a pain condition, they couldn't get addicted, or there was like a less than 1% chance of them getting addicted. So this was another myth that was propagated. We now know that's not true. Rates of addiction in people who get prescribed an opioid for pain, get prescribed by a doctor, are probably somewhere between about 10 and 50%, depending upon what study you look at. And the longer you take the opioid and the higher the dose, the higher your risk of becoming addicted. And the third myth that was propagated was that no dose is too high. So this was really a disaster, because what doctors were told is, hey, if you give a patient Vicodin and it works great for a while and then stops working, just give them more. And so every time a patient came in and had developed tolerance, and of course tolerance is inevitably what happens to a medication like an opioid and most addictive substances, doctors just kept going up and up and up to the point where, by the 1990s, early 2000s, even up to today, we see patients on astronomical doses of opioids, really frightening doses that you can't imagine don't kill them. But the reason that the doses don't kill them is because they've slowly worked their way up. And of course now we have a population of individuals with serious chronic pain on very high doses of opioids, and it's very hard to get off, right? Because now their entire system has adapted to that. So essentially that was the paradigm shift vis-a-vis pain management within medicine that contributed to the opioid epidemic. And in 2011, the CDC declared officially that we were in the midst of an opioid epidemic, and they were unequivocal about what caused it. They said it was overprescribing of opioids by doctors, like opioid analgesics for the treatment of pain, but also they implicated psychotropics like Valium and other benzodiazepines, Adderall, and other stimulants.
Very interesting. A few things come to mind, and one of them is having had a recent relative that rolled their ankle. They went and it was actually broken, like a hairline fracture. Came back with like 30 pills of OxyContin, and they were like, no, I just like, and the doctor was over-prescribing them. So it feeds into the subtitle of your book where patients may need a little relief, but then there's this over-prescription. Right. And so what is that mindset of the practitioner? Obviously, every practitioner is different, but is that funded or influenced by industry that patients need a lot of pills, or is there some kickback or incentives financially? I mean, it seemed to me very excessive. Mm-hmm.
Yeah, so a lot of people think that individual doctors are benefiting, a kickback from a pharmaceutical company. It's actually not like that. So the instances of that are really rare and reportable. What's really going on is that you have a healthcare delivery system in turmoil. And let me characterize the turmoil as follows. There are primary care doctors who see upwards of 40 patients a day. They have less than 15 minutes to try to deal with a whole host of very complex problems. It's very easy and very fast to write a prescription for OxyContin. It makes your patient feel better, at least for a while. They come back grateful, and at least you feel like in that small amount of time, you've done something. The other piece of that is that I, as a primary care doctor, I have so many patients that I have to manage on a daily basis. I don't want to field a lot of phone calls, right? So if I give you a great big bottle, then that's going to be enough to last you until you don't need it anymore, and I'm not going to get the call a week later, I'm still in pain, doctor, can you prescribe more? Yeah, can you prescribe more? It's not like the pharmaceutical industry woke up one day and said, let's get doctors to prescribe more opioids, because they've always been doing that. That is their reasons for that. That's right. So the more interesting question is, what changed in medicine such to make it's so easy for them to get doctors to do that? And part of it is this paradigm shift that we've talked about regarding pain. But the other piece of it is the way that, it's what I call in my book, the Toyotaization of medicine, how the throughput of body parts has really prioritized and preempted whole body health. So we really have, kind of an assembly line approach to medicine now, where every different body part, you've got a different doctor, they've got minimal amount of time. There's a lot of pressure on doctors to please their patients. There are these patient satisfaction surveys. And one of the easiest things to do if you've got a patient in pain is just prescribe that and send them on their way. So it's not really so much that individual doctors are somehow getting money from the pharmaceutical industry. It's that the pharmaceutical industry has infiltrated many different aspects of healthcare delivery, from all the lobbyists in Washington to even the watchdog organizations that are supposed to be keeping an eye on this, like the FDA, the Joint Commission, Federation of State Medical Boards, and they're not really doing their jobs, partially because they bought into this idea that we need to prescribe more opioids for pain, and partially because it's just like a convenient solution to the healthcare delivery problem.
Right, yeah. I really noticed that there was a problem when OIC, opiate-induced constipation. Opiate-induced constipation was on football ads. But I think I noticed it like last year, and I was like, that is incredible that we're advertising another medication for a side effect for a medication that probably people should not be on chronically. So that to me was pretty shocking. I was watching, my brother-in-law is an interventional cardiologist, and we were blown away when we were watching that together the other day. So this long-term side effects, obviously there's a lot of gastrointestinal side effects, small intestinal bacterial overgrowth, constipation. Let's kind of run down the list, and you talk about like the tolerance. So I assume neurotransmitters are affected and depression. Let's talk about some of the complications.
Right, so what is tolerance? Tolerance means needing more of the medication to get the same effect. And that is what inevitably happens in pretty much everybody who takes opioids long term. And that's essentially why they don't work. It's not that the medication itself isn't effective for pain. Opioids are fantastic for pain short term. They don't work long term because of this phenomenon of tolerance. And what is happening in the brain? Basically, it's a process known as neuroadaptation, which means that your own brain is going to continually adjust to the presence of the external opioid in order to reassert an original equilibrium or homeostasis. And it's going to do whatever it needs to do, including increasing your sensitivity to pain in order to be able to readjust back to some kind of baseline. And so for that reason, tolerance develops. And once tolerance develops, that means that if you then take away the drug, people experience withdrawal. We even see people who between doses experience withdrawal, right? So now they're even taking it as prescribed, and yet just before that last little bit before their next dose, they're already experiencing opioid withdrawal, which is really confusing for people because part of opioid withdrawal is full body pain. So they feel like, well, when I take it, it takes my pain away, and then we have to explain it's probably not doing anything for your underlying pain condition. What it's doing at this point is treating the pain that you experience from opioid withdrawal. So it gets into this terrible, vicious cycle. But getting to other side effects, you mentioned constipation. We talk about tolerance and withdrawal. Another huge side effect is depression. That's under-recognized. Serious cognitive problems. People have memory issues. Sedation is a big issue. Long-term opioids can affect hormones, so it can suppress testosterone and estrogen, which is a big issue. They can increase cardiac risks, risk of heart attack. And then perhaps, the most dangerous side effect of all is the risk of accidental overdose and death. So what opioids do is they slow down your drive to breathe, okay, and they slow down your heart rate such that you may even be taking them as prescribed, but if you increase the dose over time due to tolerance to target the pain, you don't develop tolerance to the respiratory suppressant effects. So you may take it as prescribed, go to sleep, and not wake up in the morning just because your heart slowed down so much that it stopped entirely. Or you might mix it with a little bit of Valium or,
alcohol,
a drink,
yeah.
right? And that's just enough to then tip it over. So, in 2014, there were over 16,000 deaths due to opioid painkillers.
Oh my goodness.
And a lot of people, I think, misunderstand what that amazing statistic means. They might think these people tried to suicide or they were all addicted and they took too much trying to get high. It's not true. A large percentage of people who die due to prescription opioids are taking the medication as prescribed.
Mm-hmm. So for someone that does roll their ankle, break their leg, what are your recommendations of a safe analgesic, kind of a pain modulator that's maybe not habit forming, or is there a safe way to use opioids in a short window without getting that addiction?
Right, so the Center for Disease Control has put out opioid prescribing guidelines, and basically what they are saying is doctors should dispense no more than about 3 days of opioids in the treatment of pain. So that's a powerful message. That's saying, you roll your ankle or whatever it is, really ideally you would try to get through that not using any opioids at all, using, non-opioid alternatives, including medications, aspirin, Tylenol, ibuprofen, etc. Or, use in conjunction with that other types of remedies, ice pack, cold pack, rest, trigger point injections, trigger therapy, especially if it gets to be like a chronic acupuncture, psychotherapy, mindfulness meditation, all of these things that we're generally promoting for well-being can be very effective, especially for chronic pain. But the real message is you do not want to take opioids long-term, even if your pain continues long-term, because you're probably just going to make your pain worse and you're going to develop all these other side effects and put yourself at risk for addiction. Very interesting study came out recently looking at perioperative opioid use and healing. And what they found was that people who received opioids perioperatively had slower healing compared to people who didn't. Now, when you get surgery, you need some kind of pain relief,
Sure.
right? But there are all kinds of neat tricks and things that anesthesiologists can do, like lidocaine infusions and nerve blocks. And that way they can totally avoid using opioids. And at least these limited data show that there may be better healing after surgery if you avoid opioids, which is in and of itself really interesting, right? That there's something about opioids, although they take away pain, they may actually do something to the tissue development or the hormonal or the who knows what, such that they retard or interfere with the healing process.
That's very interesting. Kind of related, but with liposuction, right? It's not a really good way to lose long-term fat. You actually need to do the exercise. So there's something involved with the process there, like you mentioned. But, let's talk about the mindset of people that are maybe more susceptible, because I've overheard family members and friends like, oh yeah, I'm going to go get a surgery. I get to get on my happy meds and things like that. Like, people do look forward to this because there is significant high there. And I was sharing with you offline, I've experienced Oxycontin before as kind of like a party drug in high school, and didn't really gravitate towards it because your body itches afterwards, and it's, I wasn't really a big fan, but there was a lot of people that got into that, and now their whole life is totally, they're into heroin and doing all these different meds. So is there something that predisposes some individuals more than others to an addiction?
Yeah, so that's a great question, and one that we have been asking ourselves for centuries, right? Why is it that some people can use substances recreationally and enjoy them and never go on to develop addiction, and other people in the same environment with the same exposures and influences will develop this really maladaptive attachment to substances? One thing that's becoming clearer is that there probably is a fairly large genetic component to the risk of becoming addicted. So if you have a parent or a grandparent who has a history of addictive substance use, then you are at about a 4-fold increased risk of developing substance use problems yourself. Now, I always like to caution that by saying, biology is not destiny, and just because there's a large heritable component doesn't at all mean that everybody who has a parent or grandparent with addiction is going to go on to develop addiction. Not at all. And there are many people who have no family history of addiction who develop addiction. But clearly there is an enduring vulnerability within the population, which is probably at about 10% of the population of individuals who, despite the most ideal environment, despite a wonderful family and a wonderful job and all kinds of protective factors, will go on to develop a substance use disorder, an addictive disorder. And we think that those people who have a lot of protective factors but still go on to develop the problem, that's probably genetic. Now, having said that, beyond genetics, there are other very well-known risk factors. One of the biggest ones is simple access. So if you live in a neighborhood where people sell drugs on the street corner, you're more likely to try drugs, you're more likely to get addicted. If you go to a doctor who's free with his prescription pad or her prescription pad and dispenses Adderall and Valium and Vicodin and fentanyl, you're more likely to be exposed, and then you're potentially more likely to be addicted. So that's another big one to consider. Another risk factor is co-occurring psychiatric illness can predispose people to develop addiction, and that's a complicated relationship between those two things. The experience of trauma. If you grew up in a family that condones substance use, either implicitly or explicitly, by modeling substance use as an adaptive coping strategy, you're more likely to go on and become addicted to substances. So it's what we call a biopsychosocial illness, because there's a biological component, but there's psychological factors and social environmental factors that contribute to the disease.
Mm-hmm. And so the environmental aspect is really big, like you mentioned, within the home and role models. So maybe if parents have a liquor cabinet, like their children will be more inclined to get access to liquor, whatever, and see their parents engaging in that behavior and think it's okay.
Yes.
And develop an addiction that way.
Right. So if you have parents who sort of model every night when they come home, they start drinking as a way to unwind, and 3 or 4 drinks later, that's sort of what they do, and they do that every night. It may not meet criteria for an obvious substance use disorder, but it's a way of demonstrating alcohol as a way to relax, as a way to whatever it is. Kids who grow up in those environments are more at risk. Yes, we do know that. Yeah. Conversely, again, this is always a bit of a controversial message because people are in such a different place in this. But we know that people who believe in a higher power or actively participate in religious activities or spiritual activities, that's a protective factor. Mm-hmm. Those people tend to have lower rates of addiction, so it's a complex beast.
Yeah, and I've noticed it a lot personally with friends that are like identified as being Christians. Generally, don't drink, don't have caffeine or coffee, and feel there's no like urgency there, or they can't be swayed. Like, oh, come on, just come out with the boys, And so that's really an interesting component. And I want to talk more about like some of the treatments and what really works. But if we could finish off, and I went to China and interviewed a lot of heroin addicts and garnered a lot of information from that. What are some of the lessons that you learned from interviewing these people that were highly addicted?
Yeah, so that was an amazing experience. I went to China and I was in a hospital that was dedicated to helping people who were addicted to heroin. And what you have to understand about China is that heroin use is highly stigmatized, not to mention heroin addiction, and that one of the main ways that they target addiction and heroin use is to incarcerate people. So they're like the treatment model is not very ubiquitous there, although it's just beginning. Basically, they have a law enforcement incarceration model. So they send people to these prison camps essentially and keep them there for 3 months. By the way, it doesn't work. When people get out, most of them just resume heroin use. But I had this interesting opportunity to go talk to people who were addicted to heroin, who were using mainly their own money to go to kind of this private hospital. It wasn't part of the larger chain of state hospitals to get treatment for heroin. And basically it was a detoxification unit. They used methadone to help them get off of heroin, gave them some kind of minimal sort of psychotherapy, and sort of sent them on their way. And honestly, I'm not sure how effective this hospital was. They made a lot of money because these people had to pay a lot of money, and they sort of were desperate because they had nowhere else to go. It was also off the grid, so nobody had to know that they were there. But there was one fascinating anecdote I heard from one of the patients. He told me he got the addiction surgery, and I was like, well, what's the addiction surgery? And he kind of explained it to me, and I gathered from his explaining it that he got a surgery where they put a naltrexone implant into his abdomen somewhere. So naltrexone is a drug that blocks the mu-opioid receptor and prevents heroin and other opioids from binding. So essentially, if you are taking naltrexone and you use an opioid, it will have no effect on you. It won't have any euphorogenic effect. It won't have any pain-relieving effect. It just won't work. And naltrexone is an FDA-approved treatment in this country for opioid addiction. So he got this implant, but it wasn't explained to him what it was or how it worked or anything really about addiction or any like recovery behaviors or any kind of psychological or social interventions. He just got the implant and he was sent on his way, and he told me, and I don't understand it because, I kept shooting up heroin and it wasn't working for about 6 months and then it started working again. It's just a perfect example of how like medication alone is not going to solve the complex behaviors around addiction. People need a lot more than just a medication, because he just kept, and that was a lot of money, and he was a rich guy, so I guess he could afford it, but 6 months of a lot of heroin that didn't do him any good.
Right.
Until the implant wore off.
And then he started to get the effects again.
Yeah, right.
And that just shows, again, like you're talking about the power of the addiction component, because we're talking about injecting into a vein, which is invasive. I mean, even if you are psychologically and biologically addicted to it, that is invasive and expensive, but he was still going through that even though it didn't. Is there any placebo effect that could be garnered from that? Did you gather any information about that?
Well, I think placebo effect is powerful, so there's always a potential for placebo effect, but clearly he didn't get any placebo effect because nothing even changed in his behavior. It was sort of a sanitized, way to put in this implant with no kind of healing really around it. Yeah. Certainly when we prescribe, medications to treat a mental illness, we know that they work better if that individual actually has a therapeutic alliance with the provider, likes the provider likes them. There's this sense of, attachment that kind of goes along with the prescription.
Yeah, very interesting. So again, that environment is really key. And we were talking offline a little bit about Vietnam and how Vietnam vets, there was a large percentage of them that were addicted to heroin. They came back into the US, and a very small fraction of them actually remained heroin addicts. So changing the environment, it seems, in addition to, like you mentioned, working with a practitioner, walking through those different therapeutic interventions that are alternatives, is a big aspect. So why is the environment how does that cause us to not think about the addiction or treat it differently?
Great. So the reason the environment is so important is because addiction is a learned behavior, and our external cues trigger those learned behaviors. And so the classic phrase in 12-step, like Alcoholics Anonymous, is people, places, and things. So if you want to stop using, you really have to avoid the people, places, and things that you used with. Because what can happen is, even after a sustained period of abstinence, you can see a person that you used to use with or be in that old neighborhood where you used to use, and it can actually trigger cravings. We don't know exactly how this works, but it's a biological phenomenon where people experience the intense and very intrusive need to use again. So it's very important to change your environment to the extent that you can, so that you can avoid some of those triggers that have you craving, that can lead you to kind of dive into that behavior without even consciously being aware of it. So one of the most interesting things when people will relapse, even after a sustained period of recovery, is they'll describe it almost like it's a dissociative experience, like a sort of a mind out of body experience, where they just sort of automaton-like start engaging in the behaviors again. So it's really important to set up all kinds of barriers in your environment to protect you from that sort of waking dream state that can happen when people relapse.
So Charles Duhigg, the book Power of Habit, so he talks about the basal ganglia, is that right? So once we do things a certain number of times, they become automated in a sense. So that's kind of that out-of-body experience that you were referring to.
Right. Yeah, I love Charles Duhigg's book. His message is so simple, but it's a good one. It's basically like, if you want to change your behavior, you have to come up with a new reward for the new behavior, which is exactly right. You have to there's a whole sequence of events that people get into, and in order to change that sequence, you have to have a new behavior followed by a new reward, and do that enough times that it gets its own neural pathway.
Yeah, interesting. So I know you don't talk about this in the book, but I'm thinking about other addictions, not just drugs and like fast food or junk food or sugar. And so if you're if you're addicted to fast food and the high of all the glucose and the associated, adrenal response and dopamine hit that's linked with that, there's a Jack in the Box and a Wendy's and a 7-Eleven and Slurpees on every corner. So do you move out to the country? And even then, it's really kind of any tips for people that, if we could transition the conversation a little bit more to effective treatments, what do you offer for folks?
Well, there are all kinds of binding techniques, self-binding techniques that we talk about in the addiction world. And what we mean by that is, little barriers that we can put in place to make it harder to access our drug of choice. So for people who are addicted to alcohol, that means not having alcohol in the house, right? Or for some people, having to go so far as to not have a lot of cash on them so that they can't even buy the alcohol for a period of time. With food addiction, it's the same thing, If your thing is carbohydrates or Twinkies or whatever it is, like, don't have them in the house. Make sure that you're not hungry when you go shopping so that you don't buy them impulsively. All the types of things that I'm sure you teach people to kind of guard against creating an environment where they're vulnerable. If we don't anticipate those moments when we're vulnerable, if we don't anticipate those moments in advance, then when we're in the moment, we're likely to make a bad choice. So in order to self-bind and guard against that, you have to anticipate the moment coming and then say to yourself, instead of doing that behavior that I don't want to do, I'm going to do this other behavior. So, tomorrow's Thanksgiving. If you know you're going to be in a place where there are going to be a lot of your foods that you don't want to consume, make sure you have alternative foods, right? Don't leave yourself hungry. And then in a state where you're potentially more vulnerable to eat the foods that you don't want to eat or that are not healthy for you.
Yeah, and other authors in this space, Chip and Dan Heath, in their book Switch, they talk about like the rider and the elephant, so kind of the emotional and logic side of the brain. So when we're in these situations where we can be tempted to indulge in, whether it's opiates or alcohol or fast foods, our emotional centers kind of override logic a little bit. So that's why we just need to remove ourselves and plan ahead a little bit.
Right, that's right.
Kind of the solution.
Yeah.
So let's kind of wrap up a little bit with families dealing with opiate addictions. I know you have a lot of solutions in your book and so forth. Can they work? Is there like a network of practitioners that can help help people like make this transition? Can you offer some resources? Because again, this is a huge issue for a lot of folks.
Well, families are very traumatized by addiction, and we do know that addiction basically functions like a family disease in the sense that everybody is affected, and family members can even get into a cycle where they're enabling the substance use because they feel trapped and incapable of doing otherwise, or they see it as the lesser of many different evils. So I think families, really benefit from education and counseling in this area. And in fact, some of the most effective treatments for addiction involve family therapies to really get a handle of what is the sort of the larger systems problems going on here. But I will say that sometimes, even with all of the education and all the psychotherapy, it can be very difficult to move a loved one toward health or toward getting out of their addictive process. And then sometimes really the best thing is to remove yourself for your own mental health and potentially for that individual's recovery. Because as long as we are continuing to enable them, giving them money or giving them housing, there may not be the incentive that they need in order to get well. So this is very hard to tell people, especially like parents of adolescents, because it's a terrifying thought to think about not caring for your child. But sometimes that's what it takes. The other thing to realize is that many people talk now about addiction being a disease of your will to choose or your ability to choose, really a frontal lobe cognitive function disease, which is to say that as long as people are actively in their cycle of addiction, intoxication, withdrawal, drug seeking, they can't really harness their frontal lobe to make informed decisions. And in those instances, I do believe people can really benefit from going to like a treatment setting where they have no access to drugs and alcohol for at least 4 weeks, or for adolescents going to a therapeutic boarding school where they have no access, if you have the means to do that. Because what that enables the brain to do is to re-equilibrate in the absence of that drug, and then hopefully get the frontal lobe sort of back online, communicating with the limbic system to be able to make informed choices. If you have somebody actively in the throes of addiction using heroin or Vicodin or whatever, their alcohol, whatever it is, they're really cognitively impaired.
Interesting.
And so it's a period of enforced abstinence is what they need in order to get their ability back to choose the path that will lead to healing.
So any chemical addiction kind of takes the prefrontal cortex offline. Is that what we're saying?
If it's to a degree of severity that we imply when we talk about addiction, yes.
Wow.
Yeah, because you get so caught up in this cycle of being intoxicated, and then experiencing the acute and protracted withdrawal. It's what George Koob, who's the head of the NIAAA, talks about, dysphoria-driven relapse, where you get to a point where your hedonic or pleasure set point is so distorted by chronic drug exposure that you need to take drugs just to feel normal. It's not even an issue of getting high anymore. You feel awful if you're not using your drug of choice. And so it's like this desperate seeking that goes into just kind of, and then it's a constant up and down cycle. So yeah, I mean, that's one of the things we try to achieve, is sort of a level brain function in a healthy range, so that people can sort of like, oh my gosh, my life has become unraveled. Because when they're in their addiction, they don't see it.
Right.
They don't see it, and there's lying, and there's cheating, and there's stealing, and they don't really see it because the prime operative has become getting the drug, using the drug, getting more drug.
Mm-hmm. What would you say to someone who says, well, alcohol, all cultures throughout the world drink alcohol, it's been around for thousands of years, pot, Indians smoke pot and whatever, mushrooms, you can make an excuse for every illicit substance or mind-altering substance that it's been throughout a part of human culture. What would be your argument against why that's okay to consume those substances?
Well, I don't even think I would argue against consuming those substances, right? Because there's a big difference between use and addictive use. I think there's an obvious hypocrisy in our system between legal drugs and illegal drugs, like alcohol and nicotine, which are legal, cannabis in some states legal, are probably no less in some cases more dangerous than some illegal substances. So that's just like historical, that there's that differentiation. And in Portugal, they've made drugs, sort of all drugs, legal, and they haven't seen a huge spike. And all the money that they were putting toward criminalizing, illicit drug use, they now put toward trying to help people who are addicted. So it's not, that universally people shouldn't use drugs. It's really the way in which they use drugs. It's the quality of their attachment to the drug, what meaning and purpose it has in their life. And frankly, it's the frequency and the quantity. So a lot of times we underestimate that, but if you're using something every day to change the way you feel in the form of a drug, that's probably not great. And the reason that's not great is because it does get you sort of part of the way up the mountain, but it probably won't ever get you to the top of the mountain, and I don't think it's the best way to the top of the mountain. Sure. Because it causes this neuroadaptation. It's addictive drugs, the dopamine hit is way too high. Our brains really aren't adapted for that. Our brains, from an evolutionary point of view, are adapted toward putting a lot of effort in to get a little bit of dopamine, right? We look for some food, and we chase the lion, and 3 days later we finally caught it, and we get a little sliver of meat that we share with our tribe, right? Just, looking way back. You take something like Vicodin or alcohol or cannabis, and for almost no effort, you get an explosion of dopamine. We're not equipped to handle that. That's not what we're evolved to do. And it actually causes a huge stress reaction in the body, from the adrenal glands all the way through. And then our bodies have to recover from that stressful reaction. And so you can imagine, if you're repeating something like that on a regular basis, you're really putting your body under an enormous amount of stress.
Wow. What's interesting, some of the before and after photos, I'm just thinking about, before someone gets on meth and after meth, and they look like 20 years older. Yeah. And I was thinking, as you were talking about that biological stress, so it seems like that accelerated aging is not just maybe a nutritional deficiency associated with the drugs, but like this physiologic reaction, like you mentioned, that yin and yang and the adrenal firing and whatnot.
Oh, absolutely. It's really, really hard on the body. It's a huge stressor to use addictive drugs. We typically think of painful things being stressors, but in truth, things that are too pleasurable are also stressors for our body.
Yeah. Anecdotally, I use heart rate variability biofeedback, and after drinking even 2 glasses of wine, your heart rate variability really drops. And so that's kind of a testimony to that resilience that we have, and so that stress response, which is really kind of fascinating. So to kind of summarize, because Thanksgiving's tomorrow, a lot of people ingest alcohol and the holidays are coming. Right. We don't want to demonize, socializing and having a little bit of red wine, but where do you put the boundaries for people? And can you say, now I'm going to feel guilty about having a glass of red wine tomorrow, right? Should we feel guilty about this, or just know that our own limitations and boundaries? What are some tips for that?
Yes, so alcohol is probably because it's legal and it's so ubiquitous and been around for so long. We have good data on what constitutes safe alcohol consumption. For an adult male, that's typically no more than 2 standard drinks per day, and for an adult female, no more than 1 standard drink per day, for a total of about no more than 7 drinks per week for a woman and no more than 14 or so drinks per week for a man. And if you look at huge epidemiologic studies and you ask people how much they drink and then you look at their health outcomes, everything from cancer to motor vehicle accidents to liver disease to death, we've been able to look at the numbers at which when people are consuming more alcohol than 14 a week for a man, 7 a week for a woman, the risk of all-cause morbidity and mortality goes way up. But as long as you're staying within that range, then you can feel pretty good about the fact that you're drinking in moderation. Now, everybody's different and people have different vulnerabilities, but in general, I advise my patients to try to keep it down to no more than 1 drink a day for a woman, no more than two drinks a day for a man. And if they can do that, then they're probably not going to get into that vicious cycle where they change their hedonic set point, that whole neuroadaptation process. Now, unfortunately, it would be great to have data like that for cannabis, but we don't have it because it's still a Schedule I drug at the federal level, so we can't easily study it. But that would be really nice to have because there are a lot of people who really, I think, would want to know what is a safe amount of recreational marijuana use, and it would be nice to be able to tell them. I would love to be able to tell my patients that, but we don't have data for that. Nicotine in general, we consider even 1 cigarette a day to increase risk of cancer, so there's probably no safe amount of smoked tobacco. On the other hand, nicotine does come in other delivery mechanisms, and that's probably pretty safe, like nicotine gum or nicotine patches. Opioids, we're saying now no more than 3 days of pain medication in order to be safe. Now, there are always going to be circumstances, people with terrible metastatic cancer, people dying with terribly painful illnesses, and there are going to be instances when for those people it may make sense to take an opioid every day, and you really want to be able to take it on a case-by-case basis. So we don't want to get too dogmatic one way or another. But in general, it would be nice to have data for every drug on sort of what is a safe or recreational amount of use. I would say in general, as a rule of thumb, you don't want to use something in pill or substance form to change the way you feel on a daily basis.
Right.
Once you're getting into like a daily cycle, then your brain is going to respond to that by adapting to that presence of that brain and changing your ability to experience natural pleasures.
Right, which is not really good. Yeah, so we can really alter our brain chemistry for the better through yoga, meditation, exercise, hiking, nature, conversation, eye contact, skin, there's a lot.
Right.
And I know we're kind of getting short on time here, Dr. Anna, but if there was one message about the book that we didn't really get to talk about, or something that you would want to share with a policymaker or a politician, or a parent, what would you want them to know about addictions and opiate addictions, or specifically that we didn't yet get to chat about?
One of the major messages in my book is to sort of educate people more broadly about what is addiction, which I feel like I got a good chance to do with you today, but also to emphasize that there are systemic problems within the healthcare delivery system that incentivize doctors to overprescribe. And until we really address those incentives and educate doctors about how to identify and intervene for people who are developing addiction, who are already addicted, then we're really not gonna, be able to get out of this problem that we're in. So that's something I really want policymakers and advocates to really hear. We have to create a system that incentivizes renewed doctor-patient attachment. Like it is the doctor-patient relationship which ultimately is one of the most important healing factors. And doctors simply don't have enough time or continuity with their patients through time to make those relationships in a way that will truly be healing. So what I'm seeing is actually a mass exodus outside of traditional Western medicine. People are going to people like you, right? Or they're going to, they're going to all kinds of coaches or all kinds of people because there's not healing happening anymore, within medicine. And I think that's driven by this terrible kind of intersection between big business and medicine and the way that medicine has become big business.
Yeah. Well, I commend you for sending that message out to people and letting us know about, kind of what's going on within the industry and some of the flaws and the issues and ways with our own choice of practitioners that we see overcome some of those obstacles and limitations and so forth. So, Dr. Anna, folks want to reach out to you. I know you have a practice here at Stanford.
Yes.
You have a website and so forth. What's the best resource where people can connect with you?
Probably, if they want to come see me clinically, they can call our intake department at 650-498-9111. If they have questions about my book, they could email me at lemke@stanford.edu.
Okay. And I'll put the links below the video and links to the book as well. Drug Dealer MD below this video. So I really appreciate you coming on the show, Dr. Anna. It was great to speak with you.
Thank you.
Thank you.